Subhi sir.
Yes, Vinayak. Hello.
Sir, we are live on YouTube, so I just
I think it's early. I think the press sir hasn't joined yet. Dr. Mohammed Kunju sir hasn't.
okay. So no worry. At meantime, the public will also be aware of that we are going live, so
Yeah.
they will join as soon as possible, and we can go.
Yeah.
We can.
I'll just call him. I'll just call him.
Okay, sir. Okay, sir.
Vinayak, should we start this early? I think it can be delayed until 8:30. It's just 8:22. I think sir is just getting ready. I just called him.
Okay, sir. So should we start right now? Yeah. Should we start around 8:30?
8:30.
Okay, sir. Okay, sir. No problem.
And that means YouTube live. YouTube live we can start at 8:30.
Acha, YouTube live you're talking about. Okay, sir.
Yeah.
No problem. I will stop that right now and we'll start at 8:30.
Yeah. That would be nice.
Okay, sir.
Okay. Because slide.
Let's see whether this poll is working. Actually, first thing. Poll.
Stop other screen sharing. Okay.
I think Vinayak, you can recording is still on, right? Vinayak?
No, sir.
Recording is on. Vinayak?
Recording is off. Should I start the recording, sir?
Yes, yes.
And now it is not needed because we are just
We are in
trying. If you
Okay.
record it when you are uploading it, that also will be there.
But it is shown as recording. Recording button is being shown as on. I'm not sure.
So you switch off that.
Because I am not getting that.
Okay.
Sir, right now we are in a practice session. So,
Oh, fine.
Sir, poll
yes,
is not
none
enabled.
of our attendees.
See the
Uh,
poll is not
poll.
enabled. Poll is not enabled.
Vinayak, enable the polls, please.
Yes, sir. Once I start the webinar, sir, I will make you the this thing, the main the host, and you can access that, sir.
Okay.
So,
Okay.
should I start the webinar, sir? So you can
Yes,
access the
you can start. You can start.
Okay, sir. Okay.
So,
Yes, sir. The webinar, the room is open, and I'm making the host, sir.
okay. So I think all are joining by now. So time is 8:27 right now.
Kunju, sir, you can access the poll, sir.
Okay. Let me see. Yes. It is there.
Can you just try
Oh.
one, sir?
We go to that question number
14 or 13.
13. Okay. 13. It is there. Launch. Kanda. Okay.
No, I couldn't see. Yeah. Yes.
Now it is launched. Okay.
Yes.
Okay. I'll end it.
Vinayak, last time there was some issue with poll actually. So if some issues come, please help in meantime.
Yes, I just talked with Mansi about this issue.
Oh yeah.
So he has given me some tips, so we can clear that, sir.
Okay, thank you.
Actually, the closing button is only at the top.
Okay.
And shall I stop sharing or?
I'll just 9, but I think people are just joining in.
I'll stop sharing.
Yes.
I'll share after we can put the other fine logo.
Sir, should I save my screen, sir?
Yeah, just
image, sir.
Fine. Yeah.
Okay, sir.
Okay. So it's 8:30. I think without delay, we'll start the session. At the outset, I would like to thank the whole fine team, especially Dr. Sudhir Kothari sir, for giving us the opportunity to conduct this session of fine neurophilia series, which is aimed at imparting neurophilia, that is liking for neurology among MD medicine as well as pediatric students, and help them in this their journey towards achieving the neurology, both neurology as well as pediatric neurology. So, and we have with us eminent teacher, one of the very experienced teacher in the field of pediatric neurology, Dr. Mohammed Kunju sir, who is a former professor and head of Department of Pediatric Neurology from Trivandrum Medical College, who is now a senior consultant in KIMS Trivandrum and also Medicity in Kollam. and he is the Dean Faculty of Medicine of Kerala University. He has a vast experience in pediatric neurology and has been a great teacher who is going. He is there going in the multiple area places all over India for imparting his knowledge. So it is lucky that we have with us, we have him with us in this fine neurophilia series. And this is the final session of pediatric neurology. And I welcome you, sir, for this session. Thank you. Over to you, sir.
Okay, thank you. Thank you. So I think I'll start sharing the. Okay, so. Okay, so good evening. We are into one more session of pediatric neurology. So we'll be continuing with the classes that we have just stopped in the last class. I think this question I have asked earlier itself. So there is the answer also. So that is many inborn errors of metabolism causes generalized convulsions in newborn, prominent hiccups, generalized seizures and lethargy, rapidly leading to coma are features of. So we all these can produce neonatal seizures because propionic acidemia, maple syrup urine disease, non-ketotic hyperglycemia, Leigh disease, neonatal adrenoleukodystrophy, all can produce. But in this case, there is a very early presentations because others may take little more time for manifestation. That is one point. And again, all of you must remember that because maple syrup urine disease is one metabolic disease where intractable hypoglycemia. So whenever there is an intractable hypoglycemia, where there is a difficulty in controlling the seizures, then think of maple syrup urine disease. Okay. Now, ichthyosis, because this question is not there in the poll. So some of you can just give the answer in the chat box. So ichthyosis is seen in following metabolic syndromes except Gaucher disease type 2, steroid sulfatase deficiency, Refsum's disease, Hartnup disease, serine deficiency disorders. I think is anybody giving the answer there?
It's the polls are already kept.
But this is not there in the poll. Okay, anybody? I think nobody is coming with the answer. But I think it's quite obvious, isn't it? Because all of you know that Hartnup disease is one where dermatitis or the desquamating eczematous vesiculobular skin lesions are the same. And it is always mentioned as the disease of diarrhea, dermatitis, and dementia. And along with that, this is another condition where you will see intermittent attacks, because usually intermittent attacks may be a manifestation, and some days you may get the questions because in that we may use the mnemonic HUPI, or I use the simple form of remembering it by remembering all the metabolic abnormalities. For example, this Hartnup disease is a amino acid metabolic abnormality. Then lipid metabolic abnormality is Refsum's disease, where again you get intermittent ataxia. Then carbohydrate metabolism, pyruvate decarboxylase deficiency disorders. Then urea cycle disorder, where again OTC deficiency, ornithine transcarbamylase deficiency, can produce intermittent ataxia. And all of you will be remembering episodic ataxia type 1 to 7, which are among them. You have a diamox responsive. So episodic ataxias can be diamox responsive ataxias. Now going to the another question, because a chromosomal study of a 21-year-old mother of a baby with Down syndrome showed T, that is translocation 1421, and she is the carrier for the translocation. So you explained that the recurrence rate will be approximately 2 to 4%, 5 to 7%, 100%, 11 to 13, and so I'll just go to the poll. That is a 13th question. So we'll go to the 13th question. At least some of you can start answering. Okay, so this here you have the translocation, trisomy, and so what is the recurrence risk? I think no, is it not there? Can't anybody? It is not there.
Polls, can you?
Are you not seeing it?
No, polls I cannot see. Polls, you can open the polls.
Oh, yes, yes, I have already. Once more, I'll relaunch the poll.
Sir, you are getting.
Yeah. Now it's seen. Now it's seen.
Okay. Okay, so majority has given 33%, because that is the usual answer, because many times it may be 1/3 will be a correct answer. But in this case, I think somehow given 5 to 7%. So at least all of you can see that, see the answer in this case is 5 to 7%, because only very few has given the answer. But do you know in which? So it is 5 to 7%. Okay, 5 to 7%. I'll end the poll and share the results here. So you see that results, because here at least you can see that most of them have given this 33% answer. Okay, so what has happened here is that
We are able to see it.
yes. I think it is over.
Yeah.
I'm trying to close it, but
it's already closed.
For you, but it is not closed for me. Okay, so that's it. So that means 100% risk occurs for 21-21 translocation. And all of you must know that 95% of what Down syndrome is because of a trisomy 21, and 4% is by translocations. And out of this, as we have mentioned, the other translocations will have a general risk of 5 to 10%. That's all. Okay, so and trisomy 21, the risk is only, that means 95% of Down syndrome patients, the recurrence rate is only 1%. So that means rest, that means only 4%. 1%, all of you know, that is mosaicism. Okay, mosaicism only. And now we have another area. Dravet syndrome is characterized by, I think most of you know what is Dravet syndrome, is characterized by all the following except the most severe of phenotype spectrum of febrile seizures. Its onset is in the first year of life. Seizures subsequently start to occur without fever, developmental delay, and autosomal dominant inheritance. So I'm launching the new question. Okay, so you can start answering. Okay, luckily the most severe of the phenotypic spectrum everybody is accepting. Its onset is in the first year of life, that is the exception. Then many have given autosomal dominant inheritance as the acceptance. So I'll end poll and give you the answers. This is the, you see there. So actually the answer up to 50%, that means only 14 people have a hold, and out of them 8, that means 57% gave an answer that autosomal dominant inheritance is the exceptions. That is correct, because even though it is a genetic epilepsy with a mutation in the SCN1A mutation in the in the 2q2431. Actually, it is most of the time it may be only a sporadic disorder. So the syndrome is usually caused by a new mutation, although rarely it is inherited in an autosomal dominant manner. The mutated gene is located on the 2q2431 and encodes for SCN1A. All of you must. The same thing can be seen in Jeff's plus spectrum. Jeff's plus spectrum is the terminology used earlier as generalized epilepsy with febrile seizure flux. Now the expansion is genetic epilepsy with the febrile seizure plus spectrum. And for those of you, what is Dravet syndrome? Because usually it starts as a focal febrile clonic seizure. So focal clonic seizure, then where the most of the time patient will be normal, it starts around again maybe a bit early than the febrile seizure age. That is, it may start before 6 months, maybe by 3 months. Then in addition to the focal clonic febrile seizure, then it will progress to have a epileptic spasm and atypical absences, and they will develop abnormal neurological manifestations like pyramidal, extrapyramidal syndromes and ataxia. So that and they will be having a progress to intractable epilepsy. So that this is what is the drug of choice or a preferred drug other than the usual anticonvulsants? Can anybody give an answer here in the chat box? Okay, so in this case, it is styropentone. Okay, so now we'll yes. Styropentone, somebody has answered. And now we'll go to another seizure-related pediatric seizure disorder related questions. The most common cause of neonatal seizure is, okay, how many of you are going to answer? Let me see. 15 the question. Okay. So please poll your answers. Vascular events, intracranial infections, brain malformations, hypoxic ischemic encephalopathy, and metabolic disturbances. So the poll, so majority is for a hypoxic ischemic encephalopathy. I'll give you the share the results and see there. So it is good that hypoxic ischemic encephalopathy is the commonest cause for a neonatal seizures. Okay, I think that is next, because metabolic disorders also we have to consider, but still all of us know that hypoxic ischemic encephalopathy are the major cause for a neonatal seizure. And again, other seizures that we can remember for an etiology of neonatal seizures by the age, that means day 1 itself, you can remember by remembering alphabet, that is A, B, C, D, E. Accident A for accidental injection of local anesthetic to the scalp. B for birth asphyxia and hemorrhages. And C for hypocalcemia. So first day hypocalcemia. So you remember that even on the first day there can be hypocalcemia. And then D for a dependency states and also drug withdrawal. For example, a mother who is dependent on phenobarbital or maybe addicted to other drugs the withdrawal of those abusing drug also can lead to seizures in the newborn. And then dependency state, pyridoxine dependency, all of you know. Again, I can start from the first day onwards. And then errors of metabolism. As I have mentioned, some conditions can present with seizures on the first day itself, like glycine encephalopathy. Glycine encephalopathy, we use the another terminology was the hyperglycemic, non-ketotic hyperglycinemia. Okay, non-ketotic, because ketotic hyperglycinemia you may encounter in other conditions. Okay. So again, some point to remember, because you might have heard about again two neonatal epileptic syndromes, because when we are learning the epileptic syndromes, two neonatal epileptic syndromes are there, which are benign. So benign neonatal epileptic syndromes, one is the benign familial neonatal seizure. Usually you can say that it occurs on the third day, but it may occur between 48 to 72 hours. So this is a third day seizure, and it may continue up to 2 to 6 months and will disappear by 6 months. So that is why it is called as a benign, and usually not familial incidents also may be there. And these children will have, because it is benign, their development will be normal, unlike other neonatal epileptic syndromes. I'll be coming to that later. And then again, you must remember that fifth day seizure. There is another type of benign neonatal seizure. So that is benign idiopathic neonatal convulsion. That occurs on the fifth day. So fifth day seizure is a benign idiopathic neonatal convulsion. And for a benign familial neonatal seizures, there is a gene that is a KCNQ2 mutation, and also KCNQ3. So that means, see, genetics is so fascinating, because the same gene which produces a benign condition like benign familial neonatal seizure, so KCNQ2, this itself can produce a severe epileptic encephalopathy, so KCN2 related. So they even call it as the KCNQE, KCNQ encephalopathy. So severe epileptic encephalopathy also can be produced by the same gene, KCN, and it is a potassium channel. So certain drugs also will be useful in that, and it is the long arm of the chromosome 20, okay, long arm of the chromosome 20, and the M-type potassium channel. Again, remember that because of the importance of benign familial neonatal seizures. And two more things we can, status epilepticus is common in benign idiopathic neonatal convulsion, even though, again, this can be asked as a multiple choice question, but is uncommon in benign familial neonatal convulsion. So they may use it as an exception question or like that. The benign familial neonatal convulsion. The status epilepticus is uncommon, but in benign idiopathic neonatal convulsion, status epilepticus can be there. Then I was mentioning about the KCNQ2 mutation. So remember that retigabin is useful in KCNQ2 encephalopathy when it presents as an intractable early infantile epileptic encephalopathy, because there are a group of epileptic encephalopathies in the early infancy. So they are called as early infantile epileptic encephalopathy, EIEE. And another early infantile epileptic encephalopathy is KCNT1 encephalopathy, which may be responding to quinidine. People publicize or publish as a very, very specific drug for these syndromes. KCNT1, quinidine is very, very dramatically they will give improvement, and it is considered as a precision treatment nowadays. So precision treatment. But in my experience, even though KCNT1 mutation is established and you somehow procure quinidine and you give to the patient, nothing happens. And because people will be publishing in a lot of things, but I don't know whether the practicality. It's just like that tiripendol, because tiripendol also considered as a drug of choice for a Dravet syndrome, and people purchase it paying a huge money, because for 1 month the treatment itself they will have to pay around 2 to 3 lakhs. and then ultimately no response. So even though, but you can learn all those things for MCQs. I think that is the only advantage. So retigabin for KCNQ2 encephalopathy and quinidine in KCNT1 encephalopathy. Okay, remember that. Then again, one more learning point in this is there is a peculiar EEG abnormality is described in that, and that is what is called as theta point to alternates. That is alternating theta burst. Theta point to, that I'll show you in an EEG. See, this is a compressed EEG where I am showing almost 20. See, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And so 2-page EEG is this one, where you are seeing a pointed theta activity. In this, there are what is called as the theta point to alternate, seen in a benign familial neonatal convulsion. Okay. So another situation is this one, NF1. So NF1, the following are the complications of neurofibromatosis except, okay, again 16th question. Okay, I'll poll launching a question. Okay, so what are the see, it is except. Okay, so always whenever you are answering, you mark on the question paper. I think nowadays if it is a computer based, I don't know, but still you try to mark on it if it allows, or else you just pin your eyes on that. Otherwise, many times except we may forget, because sometimes we may know only one answer. So in that case, we may think that that is the answer and we'll give that answer. So whenever there is an except is given in the question, you mark it so that if you know 2 answers at least, you know that it is except, and you can exclude that 2, and you can look for other 2 and identify the answer. So in this case, see, everybody has given everything. So learning disability, I'll share the answers. And this is the
Can just change the slide.
okay. I'll just
You have difficulty in closing the poll, I guess.
I'll do one thing. Okay, no problem.
For us, actually, slides are visible.
The poll I have to relaunch because the answer, most of them answered everything. So in our the answer is that see here, learning disability can happen, seizures can occur, precocious puberty can occur, and scoliosis is a very common thing. So you can see that cataracts are found in 62, 61 to 81% of NF2. So which is not seen in NF type 1. So that is the difference between type 1 and type 2. So in type 1, cataract is not seen commonly. So that is the exception. Learning disability, definitely, because many can have associated seizures and brain abnormalities. I'll be showing that. Then seizures, definitely. And precocious puberty, they can occur because of hypothalamic hamartomas. Then scoliosis because of the bone abnormalities. Okay. So I'll be coming to that also. And one more thing about the neurocutaneous syndrome. Facial porcine stain of Sturge-Weber syndrome is characterized by the following except. Again, remember that is except. Present at birth, tends to be unilateral, always involve upper face and eyelid. Its distribution is consistent with V1, means first division of the trigeminal nerve. Most children with facial porcine stain have a Sturge-Weber syndrome. Let me see whether I can share the 17. some problem has occurred now also.
So you have some.
So the polling is I'll do one thing. I think I'll stop for sharing and then share once more. Then it may be possible. Okay.
Okay, sir.
Okay. I think
Yes, sir, the screen is visible. We
see
can.
whether I can share or not. Still the same problem is there.
Are you, sir? Are you unable to access the poll, sir? Is that the problem?
Poll I can access, but
Okay.
the launching of a poll is not allowed because failed to start a poll. Another poll has started or shared. That is the thing. Whether I don't know whether the previous one is remaining there, but I have closed it properly and it is working also. You know.
Okay.
Or I think if it have, once more is it coming now? Failed to okay.
Vinayak, you can become the co-host, right?
Yes, I am the co-host, sir.
So you can access the polls and just see what is happening, I guess.
Okay, okay, sir.
Okay, I think by the time you sort it out, I'll most of you can give the answers. I think has anybody given the answer?
I think they already saw the answer.
Okay, so one point you must remember is that even though port wine stain or the facial capillary hemangioma is considered as pathognomonic of Sturge-Weber syndrome, but only in 8 to 33% of those with a port wine stain or a capillary hemangioma, the face will have the complete Sturge-Weber syndrome. So it can be a very just a capillary nevus, whether nothing else may be there. So that means up to 8 to 30. So because I have seen number of doctors bringing their kids to me and with panicking, saying that sir, there is a hemangioma, maybe a small one on the forehead. Then people will come. Then I will tell them that first of all, only this much percentage is there, so we don't have to go for investigations. And if something is there, and if the lesion is a little more extensive, then we will investigate like that. Okay. But if those who are very much anxious, one MRI can be taken. But only thing is that when you are taking the MRI, the contrast has to be taken. So that you can see that leptomeningeal angioma. So this is the most important point. So you have to take a contrast. Then this leptomeningeal, similarly, the hemangioma is on the face. So that is a port wine stain. And there is a leptomeningeal hemangioma, and there is an abnormal process of the eyelid, eye leading to glaucoma. So there are capillary hemangioma in the face, in the brain, and in the eyes. So that is the complete Sturge-Weber syndrome. But there are type 1, type 2, type 3. In type 1, all these will be there. In type 2, you will have a port wine stain and glaucoma. And then the type 3, where you will get only the brain abnormality, and the other two will not be there. So there can be isolated leptomeningeal angioma also. Today also I saw one case with the isolated leptomeningeal angioma presenting with the motor arrest, because they can have an episodic hemiplegia, and they will get recurrent hemiplegias, and later they can have an established hemiplegia also. And one more point you must remember, so this, in addition to the glaucoma, they are prone to subarachnoid hemorrhage also. Subarachnoid and port wine stain can be associated with other syndromes like Klippel-Trenaunay-Weber syndrome, because when the hemangioma is involving the face upper limb and sometimes lower limb with a hemihypertrophy. Then you use the term Klippel-Trenaunay-Weber syndrome. Klippel-Trenaunay-Weber syndrome. Okay. Then other syndromes are phacomatous, pigmentovascularis, Proteus syndrome, and Close syndrome. Close syndrome is congenital lipomatous overgrowth, muscular malformation, epidermal nevus, and scoliosis, or skeletal and spinal anomalies. This also can be associated with port wine stain. And another neurocutaneous syndrome is phase syndrome, denotes to the following except. Let me see whether this time I can share or not. Okay, I think somehow it is.
Sir, should I say the poll, sir?
Yes. You share. Try to share. So 18th question, 18th. So it is positive for some malformation.
Yes, sir.
Is it coming? Has not come. Hemangioma, anal anomalies, coarctation of the aorta, and eye anomalies. So what is the exceptions in this question?
Vinayak, it has not come yet. Meanwhile, somebody can answer in the chat regarding phase syndrome.
Okay.
Somebody has answered as C, anal anomalies.
Okay, I think that is the correct answer, because it is arterial anomalies, not anal anomalies. So this is extensive hemangioma over the face. This has to be differentiated from the capillary hemangioma of port wine stain, or a port wine stain, or a capillary hemangioma of Sturge-Weber syndrome. So this is the facial hemangioma of the face. Then see the posterior fossa anomaly. This is the posterior fossa anomaly. So you can see here, and they will be having a arterial anomaly. So see the arterial anomaly where this side. So this is the circle of Willis, where you can see the arteries there. You see that this is the vertebral artery joining together to form the basilar artery. Basilar artery you can see there, but vertebral artery of other side is not there. See the vertebral artery of the other side, that this left side is not there. Plus you see that see the carotid is also hypoplastic on that side. So that means arterial anomaly is there. So that is it. So abnormalities in that phase I'll tell once more. So posterior fossa anomalies, posterior fossa malformation, large facial hemangiomas, that is important. Then arterial anomalies, cardiac anomalies, aortic coarctation, eye abnormalities. So that is E. Then when a sternal anomaly is there, we may use the phases syndrome, or supraumbilical raphe are also present. It is termed as phases syndrome. Okay, phases. We can remember that, because neurocutaneous syndromes are always visible. It is there in the realm of both the neurologist and the dermatologist. Now, a few questions on cerebral palsy. Cerebral palsy is also the most common type of cerebral palsy associated with each time I'm trying, but somehow launching is not taking place. I think once you disable that poll for some time and then enable, then I think you may be able to do it. Can we?
Yes, sir.
In that case, we can try that. Okay, so the most common type of cerebral palsy associated with seizures is anybody has given the answer in the chat box?
Gaurav Chaudhary has answered as spastic quadriplegia. Melba Johnson has answered as hypotonic CP. These are the two answers which has come. I guess.
Okay, I think I cannot blame them also, because only after reading Nelson, recently only I understood that it is hemiplegic cerebral palsy. That,
Yamini has answered as spastic diplegia.
so I think none of them has answered as spastic hemiplegia. So here answer is spastic hemiplegia. So that is what is given in Nelson. Okay, so I think for most of the pediatric problems, Nelson is the last word. So if it is given in Nelson, it should be correct till they correct it. Okay, so spastic hemiplegia is the most common type of cerebral palsy associated with seizures, because you can remember that is a focal abnormalities will be there specifically. So focal seizures will definitely be there. Then and one more thing you must remember, that diplegic cerebral palsy secondary to prematurity is one where seizures are minimal, because especially even the seizures may not be there at all. That is another point. Then the following are features of Aicardi syndrome except cluboma of the iris. Again, is it possible? 20, question number 20, if anybody can. We are just trying each time. Somehow it is not possible.
Shirshat has answered as E, aminoaciduria.
Okay.
Mimi Bhutan. Somebody has answered as E. E is
Yes,
the answer.
yes. E is the answer. That's it. So amino acid, because Aicardi is a syndrome with severe seizures, means it is infantile spasm, epileptic spasm, corpus callosum agenesis, and retinal lacunae is the triad. But they can have a coloboma of the iris. They can have vertebral anomalies. But because it is a structural disorder, not a metabolic disorder, so aminoaciduria will not be there. And CAFE, I told you, because some points about neurocutaneous syndromes again. CAFE macules are not specific for NF1. They may be seen in the following except Noonan, ataxia telangiectasia, Fanconi, Gaucher, Hurler. Anybody is trying? Can somebody give the answer?
So it's an except question. Asha Nazimuddin has answered as B. Arnav Das has answered as C. Prashanti has answered as A.
Okay, at least one person has given the answer as A. So it is A. Noonan syndrome is exception, where again, so these are the conditions where you can get CAFE spot. Remember that, see, what is common with ataxia telangiectasia, Bloom syndrome, Fanconi syndrome? Can anybody give the answer there? What is common with the ataxia telangiectasia, Bloom syndrome, Fanconi syndrome?
Yes, Asha has answered as DNA repair.
So DNA repair abnormalities can have a CAFE. Okay, then metabolic diseases like Gaucher, Hunter. See, that again you can remember. Then all of you, I think, know about McCune-Albright syndrome having a this is CAFE. So remember McCune-Albright syndrome. Then other M's also, Maffucci syndrome, multiple Lengy syndrome, and multiple mucosal neuroma syndrome. These are the 4 M's. So Maffucci, McCune-Albright syndrome, multiple Lengy syndrome, and multiple mucosal neuroma syndrome. And all of you must remember the protein of neurofibroma is neurofibromin, NF1, and NF2 is Merlin. Merlin, that also you remember. Then remember that neurofibroma related syndromes, type 1, type 2, tuberous sclerosis, Russell-Silver syndrome. That is only one additional. And remember this Watson syndrome. Watson syndrome has another peculiarity. I'll ask you that, because see, can you give 2 conditions that produce this? What is this? Because can anybody give the answer? Can you identify the area? It is the axilla. So it is, anybody is giving the answer?
Axillary freckles. Somebody has, Arnav has answered as cross sign.
Oh, very good. That's it. So it is axillary freckling and the crow sign is the sign. And the neurofibromatosis type 1 and the Watson syndrome can have a axillary freckling. Okay, that's it. And this is an NF1. What is the arrow pointing to? Can anybody give the answer? Then I think Arnav is the one who is answering. So here also, this is an NF1. You are shown an MRI. This is a sagittal MRI and arrow is pointing to an abnormality also. So what is it? If you know the commonness, very good.
Neha has answered as optic glioma.
Yes, yes, very good. Optic glioma, which is showing a thickening of the optic nerve here. You can see that. So very good. The other association you have to remember is the hypothalamic gliomas also you can, okay, so that's it. And then see, again in NF1, you have this, which may disappear by 30 years of age. Can somebody give that abbreviations? Because anybody is giving the answer in NF1, you have the MRI is shown and see which are some lesions are there in the, yes, Lina Ranjini has given the answer. It is again Arnav Das. I think he is scoring. So it is, can you give Arnav, can you give the newer terminology for this? Because UBA was the older terminology. Can you give the newer terminology? Okay, so the newer terminology is a FASI. The earlier one is an unidentified bright object. Now the recent one is focal areas of signal intensity or a FASI. And you see it is seen in T2 weighted image. So remember that T2 weighted image, the CSF is white. And this one also the hyper intense lesions, commonly in basal ganglia areas, but other areas also it will be there, including the cerebellum and the thalamus. Okay. And one more question, because already I have given the answer. Prematurity is a major cause of a spastic diplegia, because prematurity is a major cause of spastic diplegia. And this is, but other etiologies are ischemia, hypoxic ischemic encephalopathy or ischemia, where you have a specific watershed infarct involving the periventricular region, which will give rise to periventricular leukomalacia, because in preterm, the watershed zone is the periventricular region. And in term baby, the watershed zone is the parasagittal area. So parasagittal watershed infarct you get in term babies. And because when there is an involvement of the parasagittal watershed area, because parasagittal region, see parasagittal region, when I'm drawing the brain like this, you know that this is the blood supply. See, this is the blood supply of anterior cerebral artery in that region. So this is the anterior cerebral artery, and down below. So this is the posterior cerebral artery area. So this is the posterior cerebral artery area, and this is the anterior cerebral artery area, and this is the middle cerebral territory area. So so we have that central sulcus here. So when this area is affected, you get a hip shoulder type of weakness, because this is in the hip and shoulder area. Hip and shoulder. So when the hip and shoulder is affected, you get a quadriplegia, but more of a proximal involvement. And when this area, this is the watershed zone of all the three arteries, so parieto-occipital region. So you'll get most of the time learning disorder, because sensory integration is happening in this region. And when there is a hypoglycemic brain insult, you get injury in this region, occipital region, bilateral occipital. So they'll be having a cortical visual impairment. We use the term cortical visual impairment. So that means when there is a watershed infarct in term baby, it is the parasagittal watershed infarct that is happening. In preterm babies, it will be the, see, I'm just drawing a coronal cuts there again. So this is the ventricle. This is the ventricle. And so medial part is the, see the leg fibers that are coming along the, near the ventricle, and arm fibers will be lateral. So you get a bilateral lower limb involvement. So bilateral lower limb involvement, and you can see that it is more of a diplegic cerebral palsy in a preterm baby because of the periventricular leukomalacia. Okay. And dyskinetic cerebral palsy, all of you know that it is can occur as a, because of two things. One, because of hypoxic ischemic encephalopathy, producing a acute severe infarct, leading to involvement of the bilateral basal ganglia region, leading to a condition called as status murmuratus. In dyskinetic cerebral palsy, status murmuratus. Along with that, bilirubin encephalopathy also can produce both these two types. That is the athetoid, chorioathetoid cerebral palsy and dyskinetic cerebral palsy. Okay, remember that. So spastic, and the most severe form of cerebral palsy is, here I think spastic quadriplegia is the answer, because since there is no answer of a hypotonic cerebral palsy here, because we all teach hypotonic cerebral palsy. Very good. I think all of you can give the answer. Almost everybody has given the answer as a quadriplegic cerebral palsy. Shall I think you can end the poll also. Okay, share the result. Okay, so stop sharing. Hello, okay. Have you shared the result also? Okay. I think all has answered as the spastic quadriplegia. Will stop sharing. Okay. And I'll also close here. Okay. So most, so that we have answered, but as I had told you, hypotonic cerebral palsy also can be considered as a severest form, because when that choice is there, that would be the best choice. Okay, but in this choice, it is not there. Okay, and infants with Tay-Sachs disease are characterized by the following, except convulsions, blindness, deafness, cerebral spot, microcephaly. I think, can you share the poll? Or let me see.
Everybody can answer. So polls have started. Polls. You can put in the polls.
Okay, I think share the answers now. I think all have completed. So end the poll and share the answers. Okay, you can see that deafness is given. Majority has given the answer as a deafness. Let us see the, you can stop sharing. Let us see the answers. See, because you know almost all storage disorders except serine metabolic abnormality, which will produce microcephaly. Microcephaly. Most of the storage disorders will be producing macrocephaly. So macrocephaly. The others can, even though initially they will have a hyperacusis, we know that they can have a hyperacusis or a abnormal startle response, but they can have a deafness. And the blindness, all of you know, because they have a retinal involvement will be there, and convulsions very common. Cerebral spot is there, and macrocephaly. Okay. Okay, and then coming to the macrocephaly becomes apparent by 1 year of age and results from the 200 to 300-fold normal content of this ganglioside deposited in the GM1. Okay, this is GM2 ganglioside. Okay. Now, this is a mother of 15-year-old Gayatri. Early morning fits more than 5 minutes after marriage reception party. For some months, teachers were complaining that she was a daydreamer. So, will you ask any additional questions in the history? Can anybody give the answer there?
So any additional questions can put in the chat box if such a history is given. If such a patient comes to you.
So early morning seizures, and mother, the teacher tells that she is a daydreamer. And what is the other thing the child can have or the adolescent can have? Okay, I think so. Has she become clumsy in the morning, dropping and breaking glassware? What is it? So this is a case because it is a 15-year girl. So it is a juvenile myoclonic epilepsy, and the triad of seizures are generalized tonic-clonic seizures, myoclonus, and absent seizures. So absent seizures in class, teachers will blame them. And myoclonus, they will break glass wares and other things. So from other parents will be blaming them. And once they develop a generalized tonic-clonic seizure, the doctors will treat only for generalized tonic-clonic seizure. So they will miss these two things. So then, so they will not be making a diagnosis of JME. And many times I have seen people giving phenobarbital or a phenytoin for treatment. So, and this is the one of the type of EEG abnormality they can have, generalized spike and polyspike discharges. Because they have an absence seizures also, and the age is around above the age of 10 years, you don't get a typical absence EEG. In typical absence, you get 3 per second. So here it will be 4 per second, 4 per second spike and wave activity. And also they can have a generalized spike and polyspike activity. One more abnormality they can have, that is, so it is a 4 per second spike and wave activity. And they are more prone to photoparoxysmal responses. So photoconvulsive seizures. When EEG is taken, we give photic stimulation. You can see that the photic stimulation there. Sometimes, I don't know whether for you people, they'll be giving an EEG like this, where we can see that photic stimulation by the rate of photic stimulation that is given. So here you can, I don't know whether you can see that there when I am showing. Yes, you can see there. So that is the photic stimulation rate that is given here. And you see that response there. So this is a photoparoxysmal response can occur. And coming to earlier, I told you that I'll be discussing about the early infantile epileptic encephalopathy. So this is a 2-month-old child. There is tonic seizures which are not amenable to treatment. And even at 2 months, there is no social smile. And the child is somewhat floppy. What will be the syndrome? What will be the EEG abnormality? What will be the underlying problem? Can anybody give answers for all the three? What will be the syndrome? What is the EEG abnormality? And what will be the underlying problem? Anybody is giving the answer? It is Ohtahara syndrome, burst suppression, structural abnormality. Aman has no, congratulations. So that is the answer. This is Ohtahara syndrome. So EEG will be burst suppression pattern, and the seizures are predominantly tonic seizures, and they will have a structural abnormality. So it is tonic seizures. Just see the tonic seizures, and EEG, very typical burst suppression. What are the other conditions where you get burst suppression pattern? So these are early infantile epileptic encephalopathy with the suppression burst pattern. What are the other classical situations where you will get a anybody? Can anybody give that answer? Burst suppression pattern is seen in, anybody giving the answer? Yes, very good. HIE, yes. Somebody has given us a SSP also. SSP in late stages. SSP, you get more of a radar maker complex. That is a periodic complex. So initially, But in the end or in between also you may get burst suppression, but mostly you get in a general anesthesia. In general anesthesia, you get a burst suppression pattern. That is another situation where you can get burst suppression pattern. Burst suppression. Okay. So, and the structural anomaly, what you are seeing here is a lissencephaly. With the last class, I have shown this, where a thick cortex. Okay. And I think all of you have witnessed this video. Okay. So, this is the spasm. So, you know, the triad, nowadays we use the term not infantile spasm, but epileptic spasm. And all of you know about the EEG abnormality. So, triad of infantile spasm, mental retardation, and hips arrhythmia. Okay. And the EEG is hips arrhythmia, means there is no rhythm. That is more important. There is arrhythmia. Hips means high and lofty. High and lofty or mountainous. That is where the terminology hips arrhythmia is used. And see a child who is getting seizure at the age of 3 years manifested as a frequent head drop and mental retardation. What will be the epileptic syndrome here? Anybody is giving? I think already Dr. Subir has taken epilepsies. So
Arnav has answered as best.
I think Arnav, you are answering very perfectly, but I think now you have given the answer because see syndrome.
Yamini has answered as those.
Yes, those is also okay, but when there is mental retardation is there, don't. But still, okay. That is
Asha
good.
has answered as LGS.
Yes, yes. So it is after 2 years, 2 to 7 years would be Lennox-Gastaut syndrome. Okay. The seizure patterns are stare, fold, jerk. Stare is atypical absence. Fold is this atonic seizures, and jerk are usually tonic seizures. Tonic seizures or myoclonic seizures, even though described earlier, now it is not considered as a part of Lennox-Gastaut syndrome, but atonic seizure and tonic seizures. And see there an atypical absence. Atypical absence means they'll be having more of a and other associated dystonic posturing, but again it's a part of the seizure. See there that seizure you can see very nicely there, and I'm happy that the speed is also correctly it is coming up. Okay, so you can see that chewing movement. So this is a typical absence, unlike a typical absence. Okay. And the LGS EEG is 1 to 2 per second spike and wave. I told you in absent seizures, typical absent seizures, which starts between 3 and 7 years, is 3 per second. And when the absence is beyond the age of 10 years, that is juvenile myoclonic epilepsy with absence, it will be upper rate, that is 4 per second. When it is below 3 years, that is at 2 years or so, then with an atypical absence means it is 1 to 2 per second. See here, if you look carefully, you can see that see this much is 1 second, and you see there are 2 per second spike and wave activity. 2 per second spike and wave. And one more EEG abnormality they have. Okay, so what is the other EEG abnormality? Can anybody give the answer for LGS? What is the other EEG abnormality? Can anybody give the answer? Or now again, can you give that answer? Answer for okay.
Anybody can give answer.
Any other EEG abnormality in Lennox-Gastaut syndrome? Polyspike can be. Okay, so this is another EEG of again here we are getting almost 1 per second. See, this is 1 second. 1 second, and in that 1 spike and wave activity you are getting. See the abnormality that I was asking is this is it, generalized the paroxysmal fast activity. So generalized the GPFA, that is the abbreviation GPFA, generalized the paroxysmal fast activity. usually. So here you can see that generalized paroxysmal fast activity is seen here. So this is again another EEG abnormalities that is described in GPFA. Okay. And what is this? Can you identify the abnormality here? This patient has a gelastic seizure. And what examination you will do? And can you identify the abnormality? Can anybody identify the abnormality?
Melba and Yamini has answered as
because
hypothalamus.
whenever there is a sagittal section is there, sagittal section, look there. So you can see that abnormality there. See, you are seeing it. I think take laser pointer. Okay, see there, that is the hypothalamus. I told you at the beginning. So just in front, you are seeing the optic chiasm. See, so here it is the hypothalamus. So just here you'll be seeing the mammillary body also, but in this case, because the mass, and see that it is the mass. And so what is the other, because the elastic seizure, what examination you will do? Definitely you'll have to look for visual abnormalities, etc. But this child can have a precocious puberty. Okay, precocious puberty. So that is one thing that you have to remember. And I thought that, see, in some specific neuroconduction velocity abnormalities in some pediatric syndromes, for example, GBS. So you know that it is a demyelinating type of neuropathy. So what happens in demyelinating type of neuropathy? See, this is the nerve with the myelin. The cell body is there, axon is there, myelin is there. And so you have the normal saltatory conduction. So that is happening. But when there is a demyelination, see the myelin is lost, swelled up, and then it is lost. So at that time, what can happen? Because the conduction, saltatory conduction cannot take place, and there will be very slow conduction. Okay. So conduction will be slow. So that means in demyelinating neuropathies, you can get a decrease the nerve conduction velocity. When it is an axonal form, you know that there is one form of GBS where an axonal form of GBS is there. In that case, the axon is lost. So in that case, see, the conduction can easily take place because of the myelin is there. But when we are doing the nerve conduction study, you will get a so the normal, so you give a distal stimulation, proximal stimulation, and in demyelination, so you see that there will be decrease the conduction velocity, and you see there again the distal latency is also prolonged, and in axonal, see axonal neuropathy is what happens. See the amplitude, see the amplitude of the motor compound motor action potential, CMAP. You get a, see here you see the here it is decreased in amplitude. So in axonal neuropathies you get but conduction you see almost normal. So that is what you get in a demyelinated type and axonal type of neuropathy. So what we do in a conduction study is you simulate the distal part of the nerve. So in the wrist, you get so you are giving an electrical current, and there is a response. You got a response. See, stimulus, and you are getting a response. See, that's it. So when you are getting a response, there will be a latency. That latency you can measure from the stimulus to the response. That is a distal latency. Okay. Similarly, so this prolonged distal latency may be seen in a case of GBS. Okay. And then you do the proximal stimulation. For the same nerve, you stimulate in the proximal part, that is at the elbow, and then the current goes there, and again you get a response. So that is what is called as the proximal latency. That is what you have seen in this picture. In this, so this is the proximal distal latency, and because when you are simulating the proximal part, it will take more time. to reach the recording site. That is why. And by calculating, you can calculate the velocity also. Now we'll see one more thing that can happen in demyelinating neuropathies. So because you know that in GBS, it is the radicals that are affected. Radical, actually it is a motor radiculopathy. In GBS is a motor radiculopathy. So what you do, you have to know the proximal segment of the nerve. For the, when you are stimulating the distal part as well and in the elbow, you're studying the root region. So in order to study the root, either we study the F wave and or H reflex. So F wave is obtained by using a supramaximal stimulus. You give a supramaximal stimulus. And in H reflex, you give a subthreshold stimulus. I'll just show you an animation how they can be learned. See, this is the reflex arc where you know that from the muscle spindle, the afferent impulses will go and it will synapse with the anterior horn cell, because you must understand that your stretch reflex is a monosynaptic reflex. It just the type 1A afferent. See, type 1A afferent from the muscle spindles carries the sensory information, and type 1A afferent. And see, people have a feeling that dorsal root ganglion is there is a synapse is occurring. Actually, dorsal root ganglion is the cell body of the sensory nerve, which is a bipolar nerve, because one part will be coming like this and the other part will be going to the periphery. Unlike a motor nerve, see, motor nerve, the cell body, it is a unipolar nerve. So cell body, then the axon is going like that, and then it will be supplying the skeletal muscle. So skeletal muscle, or we use the term extrafusal. So extrafusal fibers are the simple skeletal muscle, and inside the skeletal muscle you have the muscle spindle. So that is called as the intrafusal fiber. So this is the intrafusal fiber, and this is the extrafusal is our skeletal muscle. So when you are stimulating the muscle tendon, our patellar tendon, what will happen? There will be stretching, so it will stimulate the by the muscle spindle, and then the afferent will pass through the type 1A afferent, and it will travel through the dorsal root and will synapse with the anterior horn cell. Anterior horn cell will give the motor nerve, and this motor nerve, this anterior horn cell, we term it as the anterior horn cell. So that is the motor neuron for our neuron nerve. That is, for example, for quadriceps, it is a femoral nerve. So femoral nerve is coming and innervating the muscle. It will stimulate the muscle and you will get the response. So that is why I told you that the stretch reflex or your deep tendon reflex is a simple monosynaptic reflex, nothing else. But there are a lot of modifications happening at the level of anterior horn cell. There will be a lot of connections, a lot of interneurons, and you have the upper motor neuron, that is pyramidal tract. Then other extrapyramidal tract, all will come and end in the anterior horn cell, and it will modify your activities. Okay, so what? So in here, what happens in a GBS? So when the motor root is affected, you get a reflexia. Okay, so what we are trying to test is whether this motor root is affected or not. So what you do, you when give a stimulus. Usually when we stimulate here, the impulse will go in the correct manner. That is an orthodromic fashion, and it will stimulate the muscle, and you will get the normal muscle action potential. That is a compound muscle action potential. You are getting the CMAP or compound muscle action potential. But you increase the current. You can increase the current. I told you that you give a supramaximal. So then what will happen? That electrical current will pass in an antidromic manner, and it will pass through the motor nerve to the anterior horn cell. See, like that, you are increasing the current, gone, and it comes back and produces another late response. And this late response, because people have done the stimulation in the foot muscles, we use the term F wave. And you know that F wave will have a long latency, because usually about 25 milliseconds. Okay. So when there is a motor root involvement, as in the case of GBS, this will be lost. So F wave, either it will be latency will be prolonged or F wave will be absent. And to detect the H reflex, what we do is, say this is the normal muscle action potential. And when the supramaximal stimuli is given, you are getting another F response, which is a late response. In this case, we can see that 5, 10, 15, 20, see almost 23. 23 is the latency here. And so that, and for the H response, high H reflex, I told you that you are testing your stretch reflex itself. So here you give a subthreshold stimulus, because it won't be stimulating the motor nerve, but it will only stimulate the sensory nerve. So the sensory nerve will be stimulated. That is the type 1 afferent will be stimulated. So the impulse, you are giving a subthreshold stimulus. And what happens here, see the animation, because it is so quick, that is written, but you can, it will pass through the sensory nerve. It will reach the, through the dorsal horn. It will get synapse with the anterior horn cell, and then through the anterior horn cell, it will stimulate the muscle. So just see what is happening here. That's it. Okay. So you get a late response. And this is what is, so this, it will be absent in a case of GBS. Again, because this part is lost. But in a case of, because another cause for acute flaccid paralysis is transverse myelitis, because transverse myelitis, in the acute phase, you will have a hypertonic phase or a spinal shock state, but the reflex arc is intact. So you can elicit H reflex in a transverse myelitis case, but in GBS, it will be absent. So that is again a learning point. I think since it is already late, should I be continuing? I think I'll just show you one more thing which I have just bypassed. So this is it. So the nerve conduction abnormalities in the GBS, because it may be useful for you. So decreased nerve conduction velocity I have mentioned. Prolonged distal latency also I mentioned how it can happen. Then two more things, that is a temporal dispersion, because in GBS, all the nerves are not demyelinated equally, because some nerves will be conducting and some will not be conducting. So because of there is a differential conduction of the nerve fibers, there will be those which are conducting fast will generate action potential earlier, and those who conduct slower will generate action potential later. So this will give a dispersion, that means a timed response. So that is why it is called as a temporal dispersion of the compound muscle action potential. Okay, so in demyelination you get a decreased conduction velocity, because there is no myelin, so no saltatory conduction, so get a decreased conduction velocity. In axonal form you get a decrease in amplitude. Okay, decrease in amplitude. So you are doing the distal stimulation. You can see the distal stimulation, how it is being done. Distal latency also can be prolonged in an early case of GBS. Okay. And one more thing that you have to remember, and FA, we have told that FA can be absent again in GBS, and then H reflux also can be absent in GBS, and then segmental demyelination, because again demyelination can be patchy. So this may produce a manifestation called as a conduction block. So when you are doing a conduction stimulation here, see here, when you stimulate, you will get a normal response. But when you stimulate here, the conduction, the nerve impulse cannot pass easily. So you will get a decrease in amplitude when you stimulate in the proximal part. So that is what is called as a conduction block. Okay, you see here, this is the temporal dispersion. and amplitude also will be decreased. Okay, when there is a segmental demyelination. I think should I be stopping here because already what is the time? 9:40. I think shall you stop here?
I think it's the final session. It's up to the students.
Okay.
Uh,
30 students are still there. So can anybody give a chat answer if you want to continue for 5 more minutes? Okay. Okay, I'll just finish a few more simple questions for you. Can you describe the abnormality here? See, the answers are also there. So describe. There is a look here. There is a lateral movement is there, but medial movement is restricted. So you have to look for other movements. I am telling you that all other movements are normal. So in that case, so internal movement is affected. So this is a case of internuclear ophthalmoplegia. Okay, internal movement is affected, and so this is an internuclear ophthalmoplegia. And if you look carefully, you may see a nystagmus in the abducting eye. And the site of lesion is, so in this case, it is the right MLF. Which side is the adduction failure? That side you have the internuclear ophthalmoplegia, and medial longitudinal fascicle of that region will be affected. And this is a definite sign of intrinsic brainstem lesion. Okay, intrinsic brainstem lesion. In children, it may be a brainstem glioma, may be the important cause. In adult, it can be either multiple sclerosis or an infarct. Vascular lesions also can produce because an intrinsic lesion. Okay. So what happens there? So it is internuclear ophthalmoplegia. You can say that internal movement, that is adduction, that is the only abnormality. All others are the subsequent to this internuclear ophthalmoplegia, that is the medial rectus failure. So what is happening there? All of you know that in our gaze innervation. So when I am looking to the right side, or in this case, when we are looking to the left side, see what happens. So for looking to the right side and left side, I think so this is the sixth nerve. So when from the sixth nerve, we have to have a synchrony between the sixth nerve is the lateral rectus and the medial rectus is innervated by third nerve. So there must be a yoking of this movement. So this movement has to be yoked, and this movement yoking is done by the medial longitudinal fasciculus, because sixth nerve, or you can say the parapondent reticular formation of one side, will be getting the innervation from the cortex, that is the opposite cortex. So from the opposite cortex, the fibers are coming, that is a frontal eye field. From there, the fibers will be coming, and it crosses above the pons and will reach the sixth nerve. That is the best way to remember. Sixth nerve has two parts, one part for the lateral rectus. See here the lateral movement. So that is the lateral movement that has happened here. So for the lateral movement, you have the sixth nerve. And for the medial nerve, the other part of the sixth nerve, or the parapondent reticular formation, gives PPRF, give fibers to the opposite third nerve through the MLF, so that the medial rectus of the opposite side will be moving medially. So that means, remember that. So so if in this case it is the right medial lateral rectus is moving, so it is the right lateral gaze. You can remember like that. So for that, from the area 8, the fibers are coming from for the right side. For the right side, it is coming from the left side. It crosses above the pons and reaches the parapondent reticular formation, which will innervate the sixth nerve for the lateral rectus. And then from there, the fibers will come cross to the opposite side and will go to the third nerve for the medial rectus. So when this medial longitudinal fasciculus is affected, you get a this medial movement will be affected. So internal movement will be affected. That is what we get in the internuclear ophthalmology. There are other always whenever we tell about the internuclear ophthalmology, people tell about 1.5 syndrome, bilateral internuclear ophthalmology, many things. But that all you can read and understand after understanding this simple thing, that is the internuclear ophthalmology is due to the tract that interconnects the two, that is a sixth nerve and third nerve, that is MLF. Okay, and the movement abnormality is the medial rectus, medial rectus, or the internal movement is affected. But along with that, as I am showing here, you will get a nystagmus of the abducting eye also. That mechanism is because even I am trying to move my eye to one side, I can move it. But when there is a failure, what happens? Because here the lateral movement or the medial rectus movement is though affected, gaze movement is affected, but the convergence is still there. So when I am trying to move the eye to the opposite side, the convergence will come so that the adduction can take place. But once I adduct the affected eye, and so at that time the lateral rectus also will try to come to that side, but the gaze maintained is to the lateral side. So immediately the sound lateral rectus will go away. So this will produce an nystagmus. So the convergence coming in between produces the nystagmus. That is it. Okay, so that is the internuclear ophthalmoplegia, the tract MLF.
You can reduce the sound, I think.
Can you give 3 etiologies? See, I have written here JE. What is WNE? West Nile virus encephalitis. What is AIE? Autoimmune encephalitis. And encephalitic lethargica, all can produce this sort of an extrapyramidal manifestations, choriothetotic, in an acute encephalitic syndrome. Okay, acute encephalitic syndrome that you remember. And this is panda side. Can somebody give the answers? In acute situation, in which condition you get panda side? In chronic situation, in which condition you get this panda side? Yes, in chronic situation, in Wilson's disease. In acute, it is in the panda sign in JE, Japanese encephalitis. Okay, and so that's it. So here you can see a bilateral thalamic or a basal ganglia infarct, maybe again seen in a case of Japanese encephalitis, but this sort of necrotizing encephalopathy also get this finding. And there is another condition called as basal ganglia, thiamine biotin responsive basal ganglia disease, another condition. So this was a case of Japanese encephalitis. Okay, panda sign already we have understood. And what is this EEG abnormality? Can anybody give the finding? Again, I think only classical EEGs will be cut for you. Anybody is giving the answer? Because there are 30 people. Suppose I suppose that everybody is attending. Can anybody give the answer here? Very good. Aman has given them. Because side you can see the red is right and the black is left. And you are seeing the abnormality on the one side with a very, very severe slowing and a periodic abnormality. So it is periodic and lateralized to one side. So plugs. What are the? So this is a periodic lateralized epileptiform discharges. You get in herpes encephalitis. You can get it in an acute infarct. SSP, it is, I think, usually it is a generalized disease. So you don't, asymmetric is very, very rare. It is generalized disease. You can get in stroke, very good. Commonly in herpes encephalitis. So in herpes, you get, see, it's a frontotemporal involvement. It is unilateral. Initially, it will be unilateral. So frontal plus temporal hyperintensities. But later it may involve both sides also. Hyperintensity in the temporal lobe. Okay, herpes simplex encephalitis. What is this? And what is the etiology? This is a boomerang sign. So, boomerang sign. And this is called as cytotoxic lesions of the corpus callosum. cytotoxic lesions of corpus callosum. Yes, malaria, whatever you say, the answer will be correct. Because you can get this in encephalitis, you can get in a metabolic. It is only a cytotoxic lesion of the corpus callosum. So, and it is seasonal, because when there is an H1N1 encephalitis season, you get H1N1. And these are the other various etiologies. So, encephalitis, see influenza, measles, herpes, adenovirus, varicella, even SARS-CoV or COVID-19 also can produce same thing. Then bacterial, as you have mentioned, Salmonella, Legionella disease, then tuberculosis, then malaria as mentioned. So even in a postictal state also you can get this. Okay, postictal state also you can get this. And see, I'll give you. That is actually ocular flutter. So with earlier the patient had a up-gaze restriction, but up-gaze restriction has come down. So ophthalmoplegia, ataxia, and somnolence. The MRI is also there. What will be the diagnosis? Can anybody give the answer? This is a brainstem encephalitis. See, Miller-Fisher syndrome, again I have kept here, but in Miller-Fisher syndrome you get areflexia. Here areflexia I have mentioned is somnolence, ataxia, and so in Miller-Fisher syndrome you get ophthalmoplegia, ataxia, and areflexia. Okay, and both there will be IS. This is always called as Bickerstaff encephalitis. Okay, so brainstem encephalitis. The brainstem encephalitis, altered sensorial. So viruses can produce viral induced demyelination. Viruses can produce decompensation, producing a manifesting inborn error of metabolism. As we have seen, it can trigger an autoimmune encephalitis, and viruses can precipitate an electrical status. That is the fires. Fires can occur. And viral induced vascular insult. For example, in varicella, you can get a arteriopathy, and that can lead to stroke. Arteriopathy. Okay. And certain viruses will give you some diagnostic clues because of their manifestation. Because psychosis, you can get in HSV encephalitis, autoimmune encephalitis. Then, as we have mentioned, Korea. You may get in JE, autoimmune encephalitis, and other I have mentioned already. And even in viral, because meningeal sign is there, it may be ADEM or a meningitis. And asymmetric encephalopathy, you may see in HSV, focal encephalitis, ADEM, tuberculosis meningitis. Ataxia, you know that varicella can produce cerebellar involvement. And visual loss, you may get in see hypertensive encephalopathy, PRUS, remember that. And lower cranial involvement, you may get in tuberculosis, vasculitis, brainstem encephalitis. I think we must stop here because I am also getting fatigued. So HSV, it is a frontotemporal. Rabies, it is brainstem, because in rabies, it is the nucleus ambiguous is one that is affected in rabies. That is where you get the hydrophobia, rabies. Then polio, gray matter encephalopathy, leukoencephalitis. In ADEM, there are white matter plus thalamic involvement and basal ganglia involvement you may get. Cerebellum may be affected because varicella, that is why they can get an ataxia. And basal ganglia, already we have mentioned JE, Bosnian virus. And enteroviruses may have a propensity to pons, medulla, and Nipah may be predominantly affecting the brainstem, respiratory, ARDS, and even cardiac involvement. Okay, because viral tropism. So herpes simplex encephalitis, you see the temporal lobe involvement and frontal lobe involvement. That is a classical herpes simplex encephalitis, frontal and temporal. And we have learned that basal ganglia and thalamic involvement in JE, Japanese encephalitis, panda sign also in Japanese encephalitis, And in Adam, you get to see the white matter hyperintensity, thalamic and basal ganglia hyperintensity in Adam. When you are getting these images, because these are all very classical disorders, it can be always asked. So that is why I kept it. I think we will stop here, and my slides will be continuing like that. So, but I think we'll stop here. Thank you all for again being there for this session also. Okay.
Thank you, sir. Thank you very much. I am pretty sure that all would have been benefited, because it was kind of a capsule. Because not only pediatricians, I know, because with the nerve conduction study so simply explained with the good animation, all would have understood it very well. And all this, lots of things regarding pediatric neurology has been simplified for all of you. I think about 100 to 200 questions, not 200, more of the questions would have been like summarized in this, all these slides. So ask your friends to watch the video, which would be put up tomorrow. Definitely ask your friends to do that. And thank you, sir, for giving this mesmerizing webinar and talk. What I don't know what to call it, because I was taking notes all the time. So thank you very much, sir. And these 3 sessions are there in the Fine Neurophilia series. It is freely available. You can just type Fine Neurophilia. The previous 2 sessions also, those who are new to this can access it. And so thank you very much, sir, for providing time, taking your time out from your busy schedule. So thank you very much.
Okay, thank you all. Thank you all. Okay, best wishes for all of you. I think only one more 1.5 months. Okay, all of you study well. Okay, good night.
Good night, sir. Good night. Good night. Good night, everyone. Good night.